Good afternoon and welcome to our first sepsis series. There is no commercial support for today's program. The speakers and planners have disclosed no relevant financial relationships with commercial interest. If you have a question for our presenters today, please hold until the Q&A segment at the end of the talk. And if you're attending virtually, please hold, and you have a question, please enter it into the Q&A section and we'll make sure to ask that for you. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to introduce our speakers today, Dr. Jason Swaby, Dr. Daniel Robinson, and Carol Ann Gelderman. Dr. Jason Swaby is a provider with Georgia Emergency Department Services. Dr. Swaby received his medical degree from State University of New York, Upstate Medical University College of Medicine, and then he went on to complete a residency and a fellowship in wound care and hyperbaric medicine at Upstate University Hospital. Dr. Swaby is board certified in emergency medicine and undersea and hyperbaric medicine. Dr. Swaby serves as our ED provider sepsis champion on the sepsis program steering group. Dr. Daniel Robinson is a provider with the Northeast Georgia Physicians Group, specializing in hospital medicine. He earned his medical degree from American University of the Caribbean School of Medicine. Dr. Robinson is board certified in internal medicine and serves as one of our hospital medicine sepsis champions on the sepsis program steering group. And Carol Ann Gelderman is our nurse manager of the sepsis program.
I am not mic'd up, so I'm going to stand behind here just to open us up today. I appreciate all of you coming. I'm just going to be speaking briefly to bring in kind of the patient perspective. As we're hearing about all of the things sepsis with our speakers today, it's going to be very focused on what we're doing for our patients, but I wanted our patient voice to be heard. So I'm going to share a little story with you guys, a personal story, and I'm actually going to read it because otherwise I'll have a hard time sharing this. This is a post that I did in February of 2013 to Facebook, so I'm just going to read the post. 7 years ago today, our daughter, Leanne, was given a precious gift, the gift of life. During their time of grief and sorrow, a family member blessed our daughter with a heart from their loved one. Because of that, I gained so many everyday moments that I would not have had otherwise. I gained seeing my daughter leave Eggleston stronger and healthier. I gained seeing her receive an inspiration award from Gainesville School Systems. I got to celebrate with her when she scored perfect on the math CRCT. I got to see her experience her first love. I got to celebrate her hole-in-one at Chattahoochee Golf Course. I got to see her cheer in the dome during the state championships. I got to spend my first spring break with her in Daytona Beach. I got to celebrate New Year's Eve with her in Times Square. I got to see her receive the Tommy Aaron Golf Scholarship for college. I got to sit next to her when she signed to play golf in college. I got to see her high school graduation and got to hear her graduation speech. I got to see her receive the Outstanding Freshman Chemistry Student Award her first year in college, and even today, I get to spend the day walking the course at St. Augustine, watching her play golf for her school, but most importantly, I've seen her quietly touch so many lives with her story. I gained all of these moments because a family gave the gift of life. So that was in February of 2013. 1 year later, I was at around the same date, so in February, I was sending a letter to a CEO of a hospital where she was being cared for. After 2 days of unsuccessful escalation to all the doctors on her care, to the nurses, to the techs, to anyone that would walk in her room, that I thought she had an infection. She was there for a cardiac issue. My husband came in and he said, "You need to go home and get a good night's sleep. Staff are afraid to come in her room because you keep talking about her having an infection." So I went home to spend the night at home and he stayed with her that evening. The next morning, I got the dreaded call from my husband. "Get here fast, get in the car, come on, she's coding." 2 days later, we were faced with the decision no family member, no parent should have to make: withdrawing care. We did end up withdrawing care, and I was holding her hand when she peacefully passed away from septic shock. So I wanted to share that experience because so often when we get so many patients, we get all the task of what we have to do for the sepsis bundle that we forget about that the patients we serve are family members. Someone's daughter, someone's brother, someone's mother, someone's relative. And so I wanted you to hear the perspective of the patient before we started our talk today. So I appreciate you letting me share that. And I hope you can understand where the passion for our sepsis program that I embrace and what I bring into the sepsis program is all based on making sure that the life of my daughter would live on in helping other patients.
Good morning, everyone. My name is Jason Swaby. One of our learning objectives, understanding the impact of sepsis at our facility, recognizing the signs and symptoms of sepsis, and applying evidence-based research and CMS treatment strategies for managing sepsis. So what is sepsis? So sepsis is when you have an infection that has a systemic effect on the body. It's affecting the whole body. Of course, you can have infections that, a simple cellulitis or something simple that's not really causing, having any sepsis, but you start to get signs and symptoms that overwhelm the body and you end up having a systemic response to the body. So any kind of infection is at risk for sepsis. So here we talk about the whole inflammatory cascade that occurs when you have a bacterial infection and starts to overwhelm. And these are the organs all your major organs that it can affect. So chemicals released into the body have a basically inflammatory response and subsequently end up overwhelming the system and developing into sepsis. So here we talk about the different organs that can be affected: the brain, heart, lungs, liver, GI system, kidneys. So what is this slide talking about? So as you can see here, we have, these are basically our mortality for STEMI, stroke, heart failure, but this is what our mortality is for sepsis. This slide is not really talking about, it's not really we're not really talking negatively about what we're doing here. We're talking about what we're missing here, as opposed to these other pathologies which we focus on, but yet we're missing things with regards to sepsis. So what is our values-based purchasing, or why is there a big focus that we're having on sepsis now? And this is not only for this facility. This is for every hospital in the nation, actually. CMS is having CMS has created this as a big focus for all hospitals. They're starting to reward or penalize hospitals for the quality of care they are providing with regards to sepsis. Pay for performance. So what they're focusing on is not the diagnosis of sepsis, but how we're approaching these initial signs and symptoms that can develop into sepsis, and how we're approaching our Sepsis 1 bundle. So the Sepsis 1 bundle is to come within the 3 hours, and we have a 6 hour that we have to adhere to. So this is a 3 hour, which consists of collecting your lactate, your blood cultures, your antibiotics, and for those who are in septic shock, we're starting our fluid bolus if appropriate, and we'll talk about more about that later. And this is our 6 hour bundle, which again consists of repeat lactates, blood pressures for those hypotensive patients, and perfusion reassessments for these patients. So again, this is the Surviving Sepsis campaign, which many of you probably have already heard about. This is this would be actually within a 1 hour response, which is not part of what we're talking about. I'm just showing you what the 1 hour bundles elements for Surviving Sepsis campaign is. This is actually what we're focused on and what CMS is focused on, our CMS bundle requirements. And again, talking about the lactic acid, the blood cultures, antibiotics, and for those patients who lactate greater than 4 or hypotensive, evidence of septic shock, that we're initiating that 30 cc per kilo bolus. Again, this is our 6 hour bundle requirement. So we have made great strides over, at least since I have been involved. I've seen it, and it was going on even before I was involved, but watching how sepsis, how we have improved our response or our Sepsis 1 bundle compliance up until now. So we still have some challenges. So this is where our goal, where we want it to be. These are our smaller facilities, including Lumpkin, Barrow, Habersham. Unfortunately, this is where we are at Gainesville and Brazelton, which we have to bundle those together just because of their coding. But in any case, we have quite some ways to go. We've had some valleys, peaks and valleys, but we still have some way to go, so that hopefully we can get to here with Brazelton and Gainesville. So sepsis bundle compliance outcome. What this slide is really referring to is showing that a compliance with the Sepsis 1 bundle compliance, compliance with the Sepsis 1 bundle can actually lead to a decreased 30-day mortality and length of stay. So these are our aims: early treatment and preventing of worsening infection. Again, picking up the signs and symptoms that could develop into sepsis so that we can treat those accordingly, so that we can actually have early intervention on these patients. These are our criteria, which are infection, SIRS, criteria for sepsis, infection, SIRS, and organ dysfunction, and our bundle initiation, Sepsis 1 bundle initiation. You notice here billing. Our SIRS is not necessarily that we're using that to bill as sepsis, but this is, again, just early intervention to prevent sepsis. So evidence of organ dysfunction would be the definition of what is sepsis. So although we are jumping in when we see signs or symptoms that could develop into it, it's not necessarily a diagnosis of sepsis. So criteria for sepsis bundle initiation includes our suspicion of infection, or if it's confirmed infection, right? Unknown source. This is something in working with this group, is something that actually I was unaware of before, which includes COPD. My presumption has to be is that because so many times in COPD patients, we will initiate macrolides, azithromycin, or initiate doxycycline to help with their COPD in terms of decreasing the inflammation. And as a result, CMS has tagged this as a part of sepsis. So how can you avoid that, right? If they're COPD, but you're not concerned for sepsis, they may have SIRS, so increased respiratory rate, tachypnea. You just have to document accordingly that no concern for infection, COPD exacerbation only. And that would take it off of the consideration for infection or sepsis. So organ dysfunction, lactate greater than 2, hypotension, decreased MAP, creatinine that's greater than 2, bilirubin for 2 or greater, thrombocytopenia, elevated INR, PTT, or invasive or non-invasive mechanical intervention. And there you go, just as we talked about earlier, our SIRS. So also including, which I did not mention earlier, is white blood cell count greater than 12 or less than 4, or bands of greater than 10%. 10% or greater. So this is what I just talked about a little while ago. If SIRS or organ dysfunction are not related to infection, you have to document accordingly so that we wouldn't consider this as part of sepsis, and CMS is aware. So what about clinical judgment? This is where we talk about, again, if you're not concerned. So because you see SIRS doesn't automatically mean that, all right, I need to treat for infection because SIRS is here, and otherwise CMS is going to penalize our institution. No, you can use your clinical judgment, but you must document accordingly. So your documentation has to fit along with your clinical judgment. So what are clinical considerations? Patients with complex past medical history. So for instance, well, let me go on further and then I'll talk about that in a little while. Patients with unknown past medical history, organ dysfunction is their baseline. So this is where I was just going to talk about. So for instance, you have if you're considering, you saw in my prior slide where it talked about creatinine greater than 2, right? But if you have a patient who's ESRD or CKD and have a baseline creatinine of 2, for them having, if you have their lab results come as a creatinine of 2, just document it as their baseline. So they wouldn't consider that as an organ damage. Other health problems that may mimic sepsis, you look at your many tools, we have SIRS, we have QSOFA, we have SOFA, which patients need that 30 cc per kilo bolus. And consideration of if the fluid stored 30 cc per kilo bolus, is that too much for this patient, right? And you have to document as such what's your clinical considerations for those patients if they meet the criteria for those fluids, or if this fluid is going to be detrimental to their long-term health. Whereas the ED sepsis order set, which it actually, when you have SIRS that pops up, there is a suggested link for if there are any emergency medicine providers here. There's a suggested link that comes up onto your orders protocol where you can click onto, and then you can initiate your SIRS or sepsis order set. Documenting to meet our regulatory standards, and many patients screen positive for sepsis alert, even though, as we noted earlier, it's not really sepsis. And so that's your responsibility to document as such accordingly. Appropriate level of care, how does EPIC support clinical recognition of sepsis? And when you have patients who screen positive for sepsis, it does alert to nursing staff. And there, if I'm not mistaken, there is actually something that comes up on the, from the provider standpoint that actually notifies you as well. And care continuity after the patient is handed off from the emergency department to whatever respective service the patient goes on to. And of course, patients are definitely increasingly informed about sepsis. I can't tell you the amount of times I've had a patient come in and say, I'm concerned for this infection and I have had sepsis before, or they've had a family member who has had sepsis. So patients are becoming increasingly more knowledgeable about sepsis. So SIRS criteria, as we mentioned, fever or hypothermia, heart rate greater than 90, tachypnea, white blood cell count greater than 12, less than 4, or 10% bands. And this is the QSOFA criteria. So not high risk, 0 or 1, 2 to 3, considered as high risk. So again, as we mentioned, 2 or more SIRS, and this is where we talked about EPIC support. So any of these concerns, this is gonna screen BPA to consider calling for a sepsis alert. 2 or more of these, the ED sepsis management order set is going to come up, as I talked about in that link. These things come up on your link, and these are automatically highlighted. It is up to whoever is the physician or APP to select if you want to look at fluid boluses and antibiotics accordingly. So let's practice. We have an ED case study that we're going to talk about. Everyone who, I believe when you signed in, you had to jump on, put your cell phone in on that name so that we can actually use this. So we have Jane Warsaw, 74-year-old female presenting with weakness. She ambulated to the restroom this morning, but she was unable to get up from the toilet after using the restroom. EMS arrived to find her sitting in a wheelchair, assisted by in-home caregiver. Weakness worsening over the past 3 days. She reports several episodes of diarrhea. Vital signs en route includes a heart rate of 101, a respiratory rate of 22, blood pressure of 115/77, MAP of 90 with a temperature of 100.4 degrees Fahrenheit. Daughter is en route, is not here currently, and her past medical history includes hypertension and hyperlipidemia. So right away from this little blurb of what we have in front of us here, what we should be noticing is that we have a heart rate greater than 90, right? We have a respiratory rate of 22. Our pressure looks great, our MAP looks great, but we also have a fever, 100.4, right? So right away that should be screaming out SIRS to you, right? Again, does not mean sepsis, but it means SIRS, which place them at risk for sepsis. So these are your triage vital signs. And here is where you have your blood pressure. That's lower right. MAP is less than 65. Blood pressure is a little hypotensive. Fever, SATs of 93% on room air. So due to meeting criteria for sepsis, alert is called, right? And provider is reviewing their history of the EMR. And the chart review from October 14th of 24 shows patient has a history of CKD, hypertension, GERD. Baseline creatinine 1 month prior is at 2.1. Creatinine is now at 3. So, and they're hospitalized in October for UTI, Klebsiella susceptible to cefepime. Most recent echocardiogram showed the patient had an EF of 35%. So what do you have on your physical exam when you see this patient? Well, before we even get to this, so with this right here, right, patient is hypotensive. You can see this patient actually probably needs some fluids. And we notice that their SATs are at 93%, which is slightly abnormal. And again, we notice and highlight that our creatinine is 2.1, right? So that's where our baseline creatinine is, and current creatinine is greater than 0.5 from their baseline. So it's at 3 currently. So what we got on our physical exam? We have rails on our lungs or crackles. The patient has increased work of breathing. Abdomen soft, non-tender, positive bowel sounds, and mentation. They're fully responsive, able to answer questions, but very poor historian. So daughter still has not arrived. So these are your labs that you sent off. So of note, we have a bicarb of 20, a BUN of 4.9, and a creatinine of 3.0, which we noted earlier, and our bilirubin is at 2.1. We have a white count at 14.4. This is what our urine looks like, large lukes, trace blood, nitrites. Lactate is at 3. And our chest x-ray that we got was notable for some pulmonary edema, possible pneumonia in the right lower lobe, which they're recommending follow-up on further imaging. So, as we mentioned earlier, our SATs were at 93%, right? SATs were at 93%. This patient is hypotensive, may likely need some fluids. But in thinking of fluids, we also think about their chest x-ray, which shows some possible pulmonary edema. And they're already, as I noted earlier, already at 93%. So this is where you use your survey, and I want you to answer these questions. Give me a bit.
Okay, if you can, this is audience participation. If you can pull out your phone, screen the QR code, and we just have a short poll. And I think anyone on Teams can also do this. I'm gonna just flip over to the web version real quick. So what aspects of the patient's prior medical history contribute to medical decision-making in this ED case? All right, I think everyone chose the right answer.
Okay.
Looks like everyone chose the right answer, which you can see in green, all of the above. Do you want to say anything else about that?
No.
Okay.
Any questions about that?
All right, let's go to the next question. Which of the following are concerning for organ dysfunction? Select all that apply. Kind of hard to see, but the correct answers were basically the first 4. Do you want to say anything else about that?
Any questions about that?
And last question, true or false, the patient has hypotension and meets criteria for severe sepsis bundle initiation, therefore 30 ml per kg IV fluid resuscitation is always required. Do you want to talk about your thoughts with the fluid piece?
Yes. So 30 cc per kilo bolus is recommended. However, you have to think about your clinical considerations with your patient, right? This is where our clinical judgment is required. So in this patient that already has a depressed EF and already has evidence of fluid overload with pulmonary edema on chest x-ray, if we gave 30 cc per kilo bolus, we would actually be detrimental to this patient's health. So in this case, would be important for you to be documenting that 30 cc per kilo bolus would probably be detrimental to this patient's health. And this patient, you probably would just end up going straight to vasopressors as opposed to a 30 cc per kilo bolus. Just again, the concern that giving more fluids would then cause more pulmonary edema, more hypoxia, and this patient would subsequently likely succumb secondary to or require a lot more medical interventions for their care to complicating their already sick status from sepsis. So sepsis, septic shock, bundle criteria. So infection, right, more greater than or equal to SIRS, our organ dysfunction, which we note here, and septic shock, right, lactic acid and hypotension, greater than 2 episodes of hypotension. Determining time 0 when the clock starts is going to really be your documentation time or septic shock by documentation time of severe sepsis or septic shock by a physician or APP who's taking care of the patient. And your clinical criteria, again, SIRS, organ dysfunction, infection within a 6-hour span of one another in no particular order. So no order that it needs to be, just noting all of these things that are highlighting that you have to recognize that you're concerned for sepsis in this patient. So clinical criteria, infection, your diagnosis, or if you, in your differential. So if you're documenting, you're putting in sepsis in your differential, in your documentation, you need to be aware that at some point in your note, you need to be documenting if there is no concern for it, there is no concern for sepsis, it's ruled out. So if your sepsis alert called at this time, your antibiotics ordered for your UTI, your SIRS needed for your clinical scenario in your patient, in our patient actually that we had, your organ dysfunction, a need one of those. So again, hypotensive, twice the lactic acid, sepsis alert call 1730. You have your SIRS and your hypotension, severe sepsis 1735. So these times, what this is highlighting, these are your times for your things there. However, that hypotension, that sealed your deal. Your sepsis, severe sepsis was started at that time. So 2 hypertensive blood pressures, 1810 triggered for 30 cc per kilo bolus resuscitation. So suspected or confirmed infection for organ dysfunction. I think this is Dr. Robinson is going to come up and talk about here from the inpatient standpoint. All right, thanks.
Thank you, Dr. Swaby. So after all that, basically, we just repeat the stuff in inpatient. My talk is done. We can go home. All jokes aside, I think that that was excellent. Thank you, Dr. Swaby. There is a lot there to unpack, and I think that a lot of these numbers that you're seeing on the screen, a lot of the criteria is what we use for several different measures. I'm going to go back a couple slides. Maybe not. Oh, we've got a IT notification. There we go. All right, I'm going to go back a few slides. And so when we're talking about this, you know, what is the most important column in criteria here? I don't see any of our finance members, but for our folks under Brian Steinis under the organization chart, probably the last column. But really, it's a spectrum of things that define what a septic patient looks like. Sepsis is more so a clinical syndrome as opposed to a lot of our patients and what they say in terms of I caught the septic. Sepsis is basically dysregulation in your body because of an infection. And when we see that and we catch that early, then the hope is that medical interventions that we have can help reverse that course and make it so that there's not going to be any sort of issues going forward. There is a spectrum from just having an infection there all the way up through severe sepsis, which a lot of studies say we're not supposed to say severe sepsis anymore, but CMS still calls it severe sepsis, all the way up to septic shock and death. There's criteria devised by quite a few different societies, the Society of Critical Care Medicine, European Society of Intensive Care Medicine, but even they don't agree among each other what sepsis is. And so that's where our clinical judgment really does come into play. When you're talking about seeing a patient, I know that there are a lot of patients that come through our ER who probably meet admission criteria on our good days. And so we need to kind of tease out where they are, which direction they're heading, and what we need to do to help treat them. And so there's a lot of considerations that Dr. Swaby went through when they hit our ER. And just because they're not septic when they come in through the ER doesn't mean that they can't become septic when they're in the hospital. There's a lot of different criteria when you're talking about, you know, what numbers we should look at, how we should judge the patient and their trajectory. I put a few of them on the screen. There is something called a QSOFA. QSOFA is what CMS helps use to bill for sepsis. It doesn't have just a whole bunch of criteria with it. There's a lot of things that can cause changes in your respiratory rate, your mentation, and your systolic blood pressure that aren't related to infection. There's a lot of studies about QSOFA. It's not as useful as a diagnostic tool. A lot more of the studies really like this NEWS. It's the National Early Warning Score. It does not help predict the weather. It predicts whether a patient's going to become septic and move the wrong direction. You can see that it has a lot of the criteria that Dr. Swaby was mentioning to help with the ED sepsis bundle. There's a score. I can go through all of the criteria with you. It will take probably about 10 minutes, or you can just load it up on some of the apps or websites that can calculate the score for you. It is not diagnostic because, as we've been kind of harping on, none of these say infection. So you can have all these criteria. If there's no source of infection, then it doesn't really meet sepsis criteria. And again, you have to take a holistic view on the patient. Carol Ann had a very good story about her family member who had a history of heart transplant and things like that. And you have to take a lot of that stuff into consideration. And that moves that bar, that threshold, whether you're trying to figure out if you're going to have more aggressive approach or if you've got some time to figure out things. And then, of course, there's the organ dysfunction. There are certain organ systems that you need to keep an eye out for. Respiratory, there's the PaO2 over FiO2 measurement. You've got hematology, where you're talking about your platelet count, your liver, where you're talking about the bilirubin levels, kidney function between serum creatinine, urine output, the brain. I know a lot of our patients with dementia come in, but if they're off their baseline or have any sort of extra confusion or other, even hallucinations, you can use that as organ dysfunction. Cardiovascular system obviously is a big part of it, between hypotension, need for vasopressors. And then if all of these sound familiar, it's because they should. That is the full SOFA score. And it does take about 24 to 48 hours to calculate an accurate SOFA score, which is why this is something that's more used in the ICU setting as opposed to when you're first seeing a patient. All of these come into the picture. They are tools that you use to help identify septic patients. But really the big thing is that you need multiple points along the line of the patient. And so how did they look at home? How did they look when they came into the emergency room? How are they looking now? I know that there's a lot of times when we have patients, especially our COPD patients, where they come in, they have trouble breathing, they have wheezing, but otherwise the rest of their vital signs are doing pretty well, they're mentating well. These patients almost exclusively get admitted around 9 or 10 o'clock at night, and then by 7 o'clock in the morning, things go south. So you need to have a good, clear understanding of the trajectory of the patient. So for that, when you get a patient from the emergency room, we have our sepsis admission order set. So all of the bundles, all of the kind of check marks, all of the things that help CMS pay us for these sorts of patients are in those bundles. The only difference between the admission sepsis order set and the sepsis order set is that the sepsis order set doesn't have the admission order. So if you have a patient that is already admitted and then they start turning the wrong direction, this is a great bundle order set to put in to start the sepsis bundle. It'll allow you to help check a lot of those boxes. It'll have the lactic acid plus the lactic acid 3 hours later. It'll have the fluid boluses. And again, I think Dr. Swaby made a great point in terms of taking a holistic view of the patient. Patient has an EF of 25, they already look like they're fluid overload, then they may already be heading to the ICU, but if you give them the 30 mil per kilogram, they're definitely going to be heading that direction for some ventilatory support and some diuresis. So the great thing about these bundles is they already have the orders in there to say that the concern for fluid overload or renal failure or other reasons why you would hold off on that fluid bolus, that's already going to be in there. It's a hard stop. You have to select something, so it makes you kind of stop, think, act, and respond, which is a safety tool. So that being said, let's do my case study. Here we've got a patient, he's a 59-year-old male, comes in for a COPD exacerbation with possible pneumonia on x-ray. There's a lot of times where you'll have, could be fluid, could be pneumonia, could be whatever, but in standard protocol, this patient is pretty stable, started on doxycycline, azithromycin, does have an elevated white count, may or may not have had some steroids in the outpatient setting, who knows, but lactic acid is below 2, and vital signs are pretty stable at that point. He is a COPDer, we're requiring some oxygen to keep his oxygen sats where we want them, but otherwise pretty stable. He's pretty sleepy, probably because he's been working very hard to breathe, and wakes up whenever you shake him awake. He's not confused. Our typical COPD exacerbation that we see on the floor. Then, next morning, our night shift is checking on the patient before they start handing off to the day shift. Oxygen saturation's coming down. He needs a little bit more oxygen. He was at 2, now he's at 4. He's a little groggy. It's 5 o'clock in the morning. I'm also groggy at 5 o'clock in the morning, but he's very difficult to arouse. Vital signs are starting to move in the wrong direction. Heart rate's going up, work of breathing's going up. His temperature's 99.1. His normal temperature's 97, so that's a fever for him. But I know Dr. Manapali would disagree on what a fever is. And the next time I have to have that conversation with the patient, I'll definitely consult ID to help explain what a fever is to our patients. But the big thing is that our blood pressures are moving in the wrong direction as well. So appropriately, nurse alerts the APRN about this change in status. So not necessarily a formal poll, but what do you guys think about criteria for sepsis bundle? I'm seeing some nodding. Yes? Okay, good. And thank you from the back, a good shout, yes. When should we initiate this? Now, very good. So in that scenario, nursing has a couple different ways to escalate this. One that I think that we have probably never seen would be a secure chat. Sup, Dr. Robinson? Patient Jones in 201's needs more oxygen, vitals are getting worse, BP is 86/51, what do you want to do? Is that pretty good? Obviously, this patient got admitted yesterday at night. That night person is home in bed, and all we're working on is the H&P when the patient is pretty stable. So probably would get across some information. I'd go digging in the chart. I'd see what the labs looked like. I'd see where his vital signs were overnight. But maybe, just my personal opinion, maybe a better way to say this would be using SBAR, also a safety tool, such as, "Hi, Dr. Robinson," as a phone call. I'm calling about Mr. Jones in 201. The situation is his clinical condition has worsened. Are you familiar with his background? No, I just woke up. Please tell me his background. He was admitted last night for pneumonia and COPD exacerbation. Per my assessment at 5 o'clock this morning, he became increasingly difficult to arouse, requiring 4 liters of oxygen when he was only requiring 2 liters last night. Heart rate, respiratory rate, and temperature are all moving in the wrong direction, and blood pressure is also declining with 2 readings at 86/51 with a MAP of 63. I have a concern, which everybody needs to listen to that he may be developing sepsis, and I recommend we initiate the sepsis bundle and call a rapid response team. When can you come by bedside? So obviously that form of communication shows good critical thinking. It helps me move in the right direction, which is towards the patient's room, and hopefully it gets the sepsis bundle initiated for the patient as well. And that is all I have. Any questions?
Excellent. If you're viewing online and have a question, please enter it into the Q&A chat and we'll ask that for you. But in the room, do we have any questions or comments?
No, great talk. Thank you again for this detailed presentation. Caroline, every time, I've heard you before, but every time it just reminds us how important it is. Every time I hear it, it's so important to recognize sepsis in a timely manner, because the only thing that's being proven to save lives is timely antibiotics. Just speaking of the first case, again, a reminder of making sure the right tests are ordered, because patient presented with diarrhea, but I think the working diagnosis was a UTI. So I think just again, we see that the urine is abnormal in a lot of our elderly patients, but that shouldn't take our eyes away from what could be the real infection or the cause for the presentation, because a lot of the time that could be just asymptomatic bacteria. Thank you for the presentation.
Thank you, Dr. Manpoli.
Okay, hold on.
Thank you. Very good talk. Appreciate it. This is related and a little bit unrelated. It doesn't involve bundles or anything, but are you aware of the recent litigation down in Albany, Georgia? The highest lawsuit award, $70 million, and it involves sepsis. 2 doctors sadly lost, and the whole issue was the plaintiffs claimed that they used too much vasopressin, like 2.5 times, and she was a school teacher and became a AKA double amputee. But the doctors, this is more into treatment rather than just initiating the bundle. But I just would love to hear your opinion on it. It's out in the public domain, so hopefully you can discuss it. But I think the doctors also claimed they felt like maybe there was ischemia or thrombosis or something in her legs from the sepsis before she even went to the hospital. So I'd love to hear your comments. Thank you.
Yeah, absolutely. I'm not familiar with the case specifically, but I can speak more generally on kind of how that would go. A lot of times you can have a lot of different, again, sepsis is a dysregulation. So you're dysregulating a lot of different pathways, coagulopathy pathways, basal tone pathways. And so when you see a patient that is moving in the wrong direction, especially one that has heart failure that you know is not going to tolerate a whole bunch of fluids, the reason for the fluids is to increase your vascular tone, increase your cardiac return, which would thereby increase cardiac output, oxygenation of the tissues that really need oxygen and nutrients during the sepsis process. And as Dr. Manpoli mentioned, hopefully circulate the antibiotics that you're given through the IV towards the site as well. The issue that you run into a lot of times with septic patients, especially in the critical care setting, is that those pathways are so dysregulated that you start forming microclots, that you start having vasoconstriction in your extremities, And then that can obviously be extremely exacerbated by vasopressors. So, you do what you need to do to save the patient, but you also need to be aware of any sort of side effect, because every intervention that we do has side effects. When you're working with a patient that is in septic shock, as I'm assuming this patient was, being on proper blood thinners, being on the proper doses of your vasopressors, titrating your vasopressors back down when you reach the goal blood pressure, and then of course very regular and very frequent checks of not only vital signs but also distal perfusion and things like that will help guide you of which direction that you need to go. Thankfully, I'm hospital medicine, so things get to move a little bit slower for me, but definitely in the critical care setting, you're talking about every 30 to 60 minutes, you need to be reassessing the patient and moving in a different direction based on the results you get from your assessment. Not knowing the case details, there's been many cases that I've been a part of where you do lose extremities because of how sick a patient is. And that sometimes can be inevitable, but AAK can be obviously life-changing, but a lot of times if you don't take a lot of those extreme measures, you lose the patient, so that also can be life-changing.
Hi, I'm Dr. Bishnadla. I just have a question, like when do we worry about DIC versus worry about coagulopathy and microclots? Because it's a very, very fine line. And when do we when do we give the heparin and when do we stay back and say, okay, we can do this, we have to worry about DIC?
There's a lot of good studies on using DVT prophylaxis dose heparin, and that usually is a sufficient anticoagulation dose for patients in sepsis and septic shock. Obviously, it's on a case-by-case basis, and that's where I would probably involve our vascular colleagues and making sure that we have proper blood flow to extremities, but unfortunately, a lot of times you have to sacrifice parts of the equation when you're trying to save the whole. That being said, that's where frequent reevaluation of the patient definitely comes into play. But the short answer to your question is that most of the studies have shown that DVT prophylaxis dose anticoagulation should be sufficient for that, unless they do get into full-blown DIC, which you're talking about having hematologic studies that would show that.
Just wanted to make a comment about the CMS reporting. Those who do the surveillance, that's really a tough job. I see that in infection control as well. These definitions are definitions. They come from our, whether it's CMS or NHS and CDC for us in infection control. I think sometimes it takes time to update these definitions as new evidence comes along. But I think as we work on, I think one of the first few slides you shared is about the mortality. I think as we work on improving sepsis care, I think it's so important that we focus on those best practices and the reason behind the work, the why behind why we do what we do. And I think proper documentation is very important, whether we treat or assess that patient as having sepsis or not. So thank you for our surveillance team too.
Yeah, and you can see here where CMS kind of diverges from a lot of the studies that came out probably 10, 15 years ago in terms of the Surviving Sepsis campaign. So there's definitely still disagreements on exactly what's important, but I think definitely having a holistic view of the patient is the important thing. I think that there's always the joke that our my medical director would use when I was in residency is that patients typically don't read the textbooks.
I just had a quick question. You've said this before, and I thought it really explained to me as now I'm stepping into not my role here, but as a family member. But I know in the case of my daughter, and you said it perfectly, anchoring. They anchored that it was all cardiac, and they could not see beyond the cardiac to look at any other pivot to any other diagnosis. So how, as a hospital medicine, do you do that, or even ED?
From the hospital medicine side, I think that it's definitely important because we do get patients from the emergency room, and a lot of times when we're rounding on patients, they've already been seen by one of our colleagues to admit them. We may be getting them several days later, so they may have seen several of our colleagues, and there's definitely a trust that's built up there in terms that our teammates are doing the correct job and identifying the correct thing. That being said, the patients aren't static, they're dynamic, and so things can change. The biggest thing to fight against anchoring bias is to not dismiss out of hand certain features of a patient's exam or labs or vitals or something like that. If it doesn't fit, then you really kind of need to broaden your differential and make sure that what you're thinking still matches and still fits with the clinical picture. It may have fit with the clinical picture when they came into the emergency room or a couple days ago, but if it doesn't fit with the clinical picture now, then we need to broaden our differential diagnosis to figure out what has changed and why.
Also, from the emergency medicine standpoint, it's the same thing as Dr. Robinson said. Sometimes you have something a patient who fits this clinical picture, but then there's something else that's in there. And sometimes it's actually more than one thing going on at the same time, or it has nothing to do with what you initially thought and it's something different. And again, I think that's where it's important to think about your differential diagnosis and think about the patient. Obviously, the first thing you should be thinking about is the patient, and then what do you think is actually going on with the patient? So it's a broad look at what's going on with the patient to really figure out what do you think is going on. So.
And to build on that, there is spatial and temporal relations. So you have things that happen, usually they're supposed to happen in the same space at the same time, but that is not always the case. A lot of times you can have one abnormal vital sign this morning, one abnormal vital sign in the evening. There have been 2 cases that I've been a part of where that was because it was a very young patient, a previously very healthy patient, and because of that, their body was compensating. Again, it's a dysregulation of different organ systems. They don't always necessarily happen at the same time or the same organ system. If you have some dysregulation here, that gets better because of compensation mechanisms, but now you have some dysfunction over here. That also can be a clue, and those are the trickiest cases that I've been a part of, where you're just not sure if they're related. A lot of times they're not, but when they are related, it can be very devastating for the patient.
So that's interesting, because it's just FYI, when I'm teaching nursing, one of the most important things to identify sepsis is accurate vital signs. If we don't have accurate vital signs, we're dead in the water. So that's number one that we really have been preaching this year. The other is just remember, when we're talking about sepsis, we want to talk about ruling it out. When we start talking DIC and we're further down the cascade and we're in the shock, bringing people back in a meaningful way can be very difficult. However, these days with fluid, there's a very hesitancy, but we got to remember, not everybody needs the fluid, but this is distributive shock. So a leader's probably not going to fix everybody. Their tank's twice as big. So it's just one of those things to think about.
And it's those cases where you have to use your clinical judgment where you need to set that threshold. That's the important thing is that not everybody fits into the perfect mold with that. So you need to make sure, using your clinical judgment, that this patient who is normally healthy, who now has a blood pressure that's in normal range, but their normal blood pressure is like 160. Again, that's where trends really come into effect.
I just wanted to make one last comment. I promise this is my last.
No, go
I often
ahead.
hear about, we're not starting antibiotics until we have a clear picture, because we want to be good stewards of antibiotics. And this is really not the place when you don't have a clear picture. I have some patients I'm taking care of now. We don't know if it's cardiogenic shock or septic shock. You get the blood cultures, you monitor the lactate, you start broad-spectrum antibiotics, and I have a clear plan to de-escalate in that 72-hour mark based on what's going on with the patient at that time. So
That's an excellent point, Dr. Menopoli. Antibiotic stewardship is not about not giving antibiotics. Antibiotic stewardship is about recognizing when to give broad spectrum, and then rapid de-escalation once you recognize that you don't need it. It's days of antibiotics, it's not no antibiotics, so definitely a good point.
Okay, excellent. Any other questions or comments? We have nothing online.
It was a really good discussion, thank you all.
Carol Ann, hold on,
Yep.
hold on.
No,
Okay, if you're viewing online, we did put the survey evaluation link in the chat section, so go check that out. And here's Carol Ann.
I just wanted to mention Dr. Menopoli is trying to sneak out, but she's also one of our physician champions and really helps drive our program. And so appreciate her asking as many questions as she needs to.
All right, thank you very much. Dr. Swaby, did you have something else?
Yes, it was
Okay.
also just one thing I wanted to, we talk about CMS and enforcing us trying to get to SIRS and sepsis. One thing I don't think I really touched on is how is CMS going to enforce this? So starting January of 2026, they're going to be going back 2 years to January of 2024 to take money away for hospitals who are not meeting that criteria. So our hospital is at risk, as are many hospitals out there. But just in case anyone was wondering, how is CMS going to be affecting us? So that's all.
All right, thank you very much.